Welcome to the Hepatitis and HIV Virtual Education Summit Series presented by Johns Hopkins University's School of Medicine at ID Care Live. My name is Dr. Paul Sachs, and you are tuned in to a live session called New and Emerging Treatments in HIV Infection with Dr. Calvin Cohn. Before we get started, I would like to remind our audience that we will be taking questions in real time throughout the presentation. You can send me your questions anytime throughout the program through the box in the lower left-hand side of your screen. Now, Dr. Cohn is Research Director of Harvard Vanguard Medical Associates and Community Research Initiative of New England in Boston, Massachusetts. He is also a clinical instructor at Harvard Medical School. In addition, he works as an HIV clinical management consultant and internist at Harvard Vanguard Medical Associates. Welcome, Dr. Cohn.
Thanks, Paul. So, I know we have a chance to review some interesting data and our exciting field of HIV. So what I'd like to do in our time together is review the newest and emerging treatments, still not yet approved, but the ones that we anticipate reaching approval sometime in the next year or two. So while we get the focus of this is on new treatments, I thought I'd just start with the background of where we are now, since after all, new treatments are meant to improve on what we now have. So these are the 4 regimens recommended by the IAS USA guidelines, as you know. The guidelines recommend 4 regimens, all based on tenofovir FTC with either efavirenz as the single tablet regimen called Atripla, or with boosted atazanavir, boosted darunavir, or raltegravir. It's fair to say that while each of these regimens are excellent with regards to the criteria listed above, none of them are considered perfect. Each one of them has some flaw.
Just before you go on, you mentioned that these are the IAS USA guidelines, but these, I believe, are the DHHS guidelines. And it's worth also just thinking that how do the IAS USA guidelines differ?
Well, it's a good point. So in fact, what's interesting, I think, about these 4 regimens is that they appear in all guidelines internationally, IAS USA, DHHS, European guidelines. These 4 are there. The only ways that guidelines differ actually are how many other regimens they add to these 4. So these 4 are in some ways the core of worldwide. I'm not aware of any guideline that, other than the British guidelines, that are trying to be even more parsimonious and pick only one regimen for everybody to start on, although even they would agree that there's no one regimen perfect for everyone.
But just for example, the IAS USA guidelines now include abacavir lamivudine as a choice for initial therapy as long as the HIV RNA is less than 100,000.
Exactly.
So
and in some ways what guidelines do is they really determine what is the best use of a recommended regimen with an asterisk for groups that shouldn't get it, or just to have a second table for groups that shouldn't get a certain regimen. So in some ways it's really more a matter of style than disagreement. This regimen basically has the 4 that they think are best for everyone, and then a second table, as you mentioned, with things like abacavir 3TC.
So let's hear about some new data.
I agree. So let's start with rilpivirine, which is meant to join these 4 and is now, at least in terms of the DHHS, on the alternative pathway list. And we have some recommendations from IAS as well as to why it deserves to be on the alternative list and possibly moved up based on the STAR study. Since after all, the guideline committee reviewed ECHO and THRIVE, which were the licensure trials for rilpivirine. But more recently, we had a chance to present the open label STAR study. So the design of this trial is the key. This is an open-label trial in which patients took either the rilpivirine single tablet with tenofovir FTC, marketed in different countries by different names. In our country, it's Complera. Across the pond, it's Eviplera. And this was compared open-label to Atripla. The design of this mimicked clinical practice, unlike the double-blind trials of ECHO and THRIVE. And because of that, perhaps this might reflect what we might see in clinical practice, just simply based on this is what we do. We give a single tablet.
But you know, playing the strict statistician epidemiologist, isn't a double-blind study better?
Well, let's put it this way. There are pros and cons to both designs. This design certainly mimics clinical practice much more than a double-blind design. So that's what these data kind of reflect, is what we would see perhaps if we prescribe these in clinical practice for a patient who could take either one. Now, a couple of things about rilpivirine that make it less than perfect. For example, you can see that patients had no evidence of a PPI used because the drug requires acid. It's taken with food, and certainly that's likely at some point in the day patients will take it with food, but nevertheless it has to be paired with food for best absorption. You can see some of the demographics of who enrolled in this pretty large trials. You can see almost 400 people per arm done in this global study. These are the primary results at week 48, the percent with virologic suppression broken down by the viral load at 5 log, which was predefined in the protocol. And you can see for those patients less than 100,000, 89% on the rilpivirine single tablet had virologic suppression, 82% on efavirenz, and you can see the point difference and then the confidence interval around that. For less than 100,000, certainly the confidence interval was greater than 0, certainly supportive of the concept of superiority. For those greater than 100,000, that was lumped together, and you can see again the point estimate and the confidence interval, which does not cross minus 12%, allowing us to at least say non-inferiority, although you can see at least numerically efavirenz does better in that group.
So why is this 100,000 threshold so critical for rilpivirine-based regimens?
Well, I think that the next slide actually gets into it, although you can see the little bit of a cartoon here about the post hoc analysis, because in ECHO and THRIVE, we saw that at least in one of the two studies, if not in both, there was some evidence of decreased virologic suppression above 100,000. So that's why we looked at it this way, which is the percent with virologic failure, forgetting now adverse event failure, virologic failure. And you can see that the right two bars for ECHO and THRIVE are the reasons we broke it down by 5 log in STAR as well, because as we march up the virologic strata, you can see increased amounts of virologic failure on rilpivirine more than efavirenz. But interestingly in STAR, the percent with virologic failure was the same, less than 100,000, 5 and 3% to the extent that that's the same. And 100,000 to 500,000, 10% on rilpivirine and 9% on efavirenz with observed virologic failure. And indeed, not all of those virologic failures have resistance on rilpivirine, only half of them had virologic resistance to the drugs. So this was certainly supportive that that 5 log cutoff seen in ECHO and THRIVE may not necessarily be true for the drug as we use in clinical practice, since here, taking a pill once a day with food had a rate of virologic failure that was similar for rilpivirine and efavirenz, with virologic failure being a similar number.
Now you mentioned not all of the patients who fail have resistance, and that's probably related to adherence issues and other factors. But if resistance does develop, what are the consequences for rilpivirine versus efavirenz?
An important consideration, absolutely. So in this particular study, we saw the pattern just like we saw in ECHO and THRIVE. On efavirenz, we see K103N, which confers cross-resistance to some, though not all, of our non-nucleosides. And we saw a lower percent develop the M184V nucleoside resistance mutation. But as in ECHO and THRIVE, we saw the same pattern here. Rilpivirine selects for a particular mutation called 138, and that mutation, unfortunately, can cause cross-resistance to etravirine. And so as a result, there is obviously a desire to avoid resistance at all. We also saw a similar number who developed non-nucleoside develop nucleoside resistance, again, mostly 184V.
Okay. Yeah.
So it is a trade-off in the use of the drug. So then why would somebody use this instead of that?
I was going to ask you
exactly
that question.
So this is the answer to that, is that it was better tolerated. You can see far fewer patients had any nervous system side effects and far fewer psychiatric effects, which is most of the abnormal dreaming that's typical for starting on efavirenz. And you can see in terms of the bottom line, how many patients said at the end of the year, I need off this regimen because of intolerable side effects. We had 2.5% on the rilpivirine regimen and almost 9% on efavirenz. Those 10 cases, I did have a chance to review them, and some of them are not even drug specific. One of them, for example, is acute hep C, which of course has nothing to do with rilpivirine. No. So the rate of tolerance on rilpivirine, both as an initial regimen and over time, is certainly better than efavirenz.
And the drug's been out now long enough for us to have our own experience with this, and certainly goes along with what the clinical trials say.
I think so.
An easier drug to prescribe than efavirenz.
Absolutely. The conversation of starting it is certainly a shorter one, since we don't have to advise people of what they might experience with efavirenz, since this seems to be pretty clean to start with.
Pill is smaller too.
The pill is a little bit smaller as well, which is a plus. And because some clinicians would prefer to have even less to worry about in terms of that virologic data that we shared earlier, the SPIRIT trial is informative, because the SPIRIT trial was in virologically suppressed patients who were on a boosted PI.
So it's very important that our watchers understand this is not a treatment-naive study we're showing here.
Absolutely.
This is patients who are virologically suppressed
on a boosted PI, who had no evidence of prior resistance to any nucleoside or non-nucleoside. So essentially wild-type virus when they started the PI and have been virologically suppressed since taking one.
Okay.
So this study is a classic switch study in that population, done mainly because, number one, patients on a boosted PI could simplify a regimen to a single tablet, and number two, we might expect to see some lipid improvements in a non-boosted regimen. So that was the purpose of this trial. As you can see here, the basics about the study design that we reviewed, the primary endpoint at week 24 with follow-up to week 48. One other insight, however, is that the historic pre-treatment viral load, whether it was below or 100,000, made no difference to the success of switching to rilpivirine.
Now, I know the answer to this question, but I'm going to ask it anyway.
Go ahead.
Why do you think that is? Why is the viral load before treatment not indicative of treatment failure subsequently in this patient population?
Well, I'd almost ask it the opposite. Why would you think it would be? Since, after all, your current viral load...
But it's been a question for some time in our field with controversy.
In fact, it has been a debate, and I certainly have weighed in on that debate before we had these data. I actually favored this answer, which was that I didn't think it would matter, since your current viral load is your current viral load, and that's what the drug is working against.
Which is so much tinier than your pre-treatment one.
Exactly.
I mean, when you're virologically suppressed, the amount of virus that's there is tiny compared to untreated patients. Now, I've noticed in many switch studies that the longer a person's virologically suppressed, the more likely they are to have success on the switch regimen.
That's right.
Why do you think that is?
Well, there are some thoughts about that in terms of cellular activation being calmed down, and therefore the new regimen has less activation to fight against in order to maintain suppression. So there are reasons why it might be true.
Yeah. Also could be that selects for better pill
adherent
takers.
patients, absolutely. So, and that's why in some ways we'll never know for sure. It's multiple factors.
Yeah, it could be also the reservoir size is actually tiny.
A little bit smaller, although that one's probably even more...
speculative.
Yes, exactly.
All right, so these are reassuring results.
This is reassuring results. I think one other piece that's perhaps interesting is on this, which is that this study did allow patients who had a pre-treatment K103N on the study. Why? Because at least in vitro, K103N does not alter the activity of rilpivirine. Yeah. Now, this was not a treatment study for starting therapy in somebody with K103N rilpivirine. No. This was maintaining suppression with historic K103N. And indeed, almost every patient with K103N before their PI maintained suppression on rilpivirine. So this is, again, reassuring data, but not the same as I have a patient with K103N, can I start on rilpivirine?
Yeah, but you know, since one of the reasons why people end up on boosted PI regimens is, in fact, the presence of K103N at baseline.
That's right.
This provides some comfort about this switch strategy.
Yeah, and if a patient would prefer to be on a single tablet regimen, this again at least gives us now one single tablet regimen that's an option for that patient. Good. So another reason to make this switch is not just for the simplification. This goes from usually 3 or 4 pills down to 1. But another reason is summarized here, which is the change in lipids. And we clearly know that some, though not all patients on a boosted PI can have altered lipids in the wrong direction. They'll have too high an LDL, too high triglycerides. And not surprisingly, when they switch to the rilpivirine regimen, here shown in blue, you can see the patients improve their lipid profile with the greatest improvement in triglyceride fractions, although there is an improvement in LDL as well. This study also reported one of the first improvements, a significant improvement in the total cholesterol to HDL ratio, which is the right measure to use. We continue to debate that, as do our cardiologists. Yes. Nevertheless, the lipid fractions do seem to improve.
Have you noticed that the cardiologists are now going back to LDL?
I have noticed that.
Yes, so they are, after years of telling us that we should not focus just on the LDL, they're going back to saying LDL is the most important, and indeed, it's much better here.
Here it is. And these are just, of course, average improvements, depending on where the patient started and what PI they're on, could influence how much they improve. So this certainly did offer an option for patients to switch. You can even see we analyzed it by Framingham risk score, and patients do improve because these lipids are potentially clinically meaningful. Great. So this was one option for the role of rilpivirine in our patients.
Before you go on, I just one of our participants has a question, and really it's about the use of co-formulated tenofovir FTC rilpivirine. Okay. When would you use it first line?
Sure. Well, I think that at this point we can say that the data are supportive of using it first line in a patient whose viral load, pre-treatment viral load, is less than 100,000. I showed the data above 100,000 earlier, and in the STAR study, 100,000 to 500,000, the rate of virologic failure is similar to efavirenz, though there is perhaps more consequence if there is failure with resistance. Nevertheless, it gives great support to less than 100,000 starting on a rilpivirine regimen, as well as any of the other 4 or 5 choices. Why would you pick this one? Well, I think that it is, at least when this study was done, the only single tablet regimen that was not based on efavirenz. And so as a result, that might be attractive to somebody who wants the simplicity of a single tablet regimen, but didn't want the baggage, if you will, that comes with using efavirenz.
Okay, good.
So I think it's as simple as that.
All right.
But as you know, we have progress and we've moved on, and so we now have the third single tablet regimen available to us. We've had it for about a year, and in other countries they're getting approval in Europe as we speak, in several countries. And it is marketed as the word Stribild universally around the world. It is a 4-drug combination, as you know, of tenofovir, FTC, the integrase inhibitor elvitegravir, and a novel booster called cobicistat. And that's because elvitegravir requires a booster for adequate exposure.
Stribild.
Yes.
What's up with that name?
Well, it's not too complicated. If you look at the word Stribild, it starts with STR, single tablet regimen,
yes.
and the Ibold is just Ibold. It's just a unique sound, just to give it something unique.
And like many drug names, we don't know whether it's Stribild or Stribild.
Well, I'm told the preferred pronunciation is Stribild, but you can call it however you'd like. So in these 2 double-blind trials that were done, it was done in a double-blind manner. One trial was Stribild versus the co-formulated efavirenz tablet known as a tripla. Patients received they received 2 tablets. One was real, one was the placebo.
So that's really our only double-blind study of 1 tablet versus 1 tablet plus matching placebo.
That's right. So this would be that one here, exactly right. We also have then the other design, and that one in which the Stribild went up against the boosted atazanavir tenofovir FTC, once again done in a double-blind manner. So in this case, patients were taking 4 tablets once a day. Thankfully, in that case, both cases with something to eat, since while atazanavir is good with a meal, so is Stribild. Stribild is preferred to be taken with just something to eat. You can see the requirements of who entered. It was essentially patients whose virus was susceptible to the drugs in that regimen. Of note, if you had, for example, evidence of efavirenz resistance, you could go in the atazanavir trial and vice versa. So otherwise, the study was wide open. Patients with any CD4 count were eligible. And importantly, the restrictions here, what makes this less than perfect, is that the estimated GFR had to be greater than 70. Why we'll get into in a moment, but nevertheless, there's a renal issue that we have to understand for this drug.
And just before we get into the results, talk to me a little bit about renal impairment in HIV. Among treatment-naive patients, how common is this to have an eGFR less than 70? And compare that to your treatment-experienced patients.
Absolutely. So I think I'll say it in a couple of different ways. The first is that it would really depend on where in the epidemic you are practicing, since there clearly are demographics of patients with much higher rates of renal impairment. Patients with a history of active injection drug use, for example, have more renal impairment. Obviously, black race is associated with more renal impairment. Nevertheless, these studies accrued the numbers of patients listed here. As you can see, 700 in each trial in a matter of a few months, suggesting that most practices have a large majority of our patients with intact renal function.
Yeah, I mean, it's been my experience that among treatment-naive patients, this is not really an issue. Among treatment-experienced patients, however, especially those who've been on therapy for 10 to 20 years and are older and have multiple comorbidities associated with aging, renal issues get to be much more problematic.
I think that's right, and that's actually one of the reasons for one of the newer drugs that we'll be getting into after we review the data on Stribild. So, unlike in rilpivirine, there is no difference in the rate of success or virologic suppression by baseline viral load. And that was the point, of course, of this analysis. Done here, less than 100,000, greater than 100,000. And here the breakpoint was 400,000, done only because there were so few patients above 500,000 that the breakpoint was felt to be 400,000 to just have some power to take a look.
Why so few patients above 400,000?
Or even above 500,000. I think it's simply just the fact that in this study, the CD4 count was a little bit higher than previous trials, close to 400, maybe because all of us are getting more comfortable with earlier treatment for more of our patients.
Yeah, I've anecdotally, everyone's noticed this, but it's become especially notable the last few years, is that these treatment-naive studies, the entry CD4 cell count median at entry is getting higher and higher and higher.
Sure.
So people are treating earlier. Patients are accepting of treatment earlier,
Yep.
and also I think it says that our HIV testing initiatives
Agreed.
are getting better, and we're
Agreed.
finding people
we are
before
finding people earlier. I
they
would
have
totally agree. I think all of that fits into what we're seeing in these trials. And reassuringly, regardless of the viral load, we have something here that works just as well. You can see the two comparators, all three working equally well with this near 90% success regardless at week. And this is, I'll point out, week 96 data. This is now 2 full years of this trial. So we also have the breakdown by CD4 count shown here, and there are studies historically that show lower rates of success at lower CD4s, and it's not entirely clear why CD4 should matter, since after all, these are antivirals. Why would the number of CD4s matter?
Would you like to know the answer?
Well, go ahead.
I'm not going to tell you. No, the reason I think is that all of the non-viral factors are worse in patients with low CD4. You know, the inflammation, immune activation, tolerability is always worse in patients with lower CD4. And so all of those factors combined make the outcome worse, you know, independent of viral load. And it was also seen, remember, in all of the salvage studies, even going back to infevrotide and everything, the lower the lower the CD4, the worse the outcome.
I'll actually add one more, which I assume you'll agree with, which is that if a patient is so distant from medical care to show up with a CD4 count of 20.
You got it.
This is certainly somebody who is not enamored with the medical care system or too connected.
Yes.
So that could be another predictor.
Correlates with pill-taking behavior.
Yes, and encouragement to do so. So I think that it is not surprising to me that we see certainly some evidence for at least 2 of the regimens that there's a somewhat lower response rate. Now, the main difference is not with the boosted atazanavir or even with a triplet here, as you can see. The main difference shows up a little bit with Stribild, and in the text we have the subset who are CD4 count less than 50 at entry. And there were 30 such patients, and you can see here that if they were assigned to a triplet or boosted atazanavir, they generally did well. There were, however, more patients who received the elbitergovir regimen, and we did see some virologic failure. So that at least raises a question as to whether this is the right regimen for somebody who presents with a late presenter with advanced disease. It's not clear if this is biologic or behavioral. Nevertheless, this is the one piece of caution perhaps for initiating. Nevertheless, I think if somebody shows up with less than 50, we don't have time for the resistance test. Those are the patients who get the boosted PI right off the bat anyway.
Often that's the case. Yeah.
So then we take a look at the implications for lack of suppression, virologic failure. You can see that about 7%, regardless of the regimen, had observed virologic failure for the first 2 years of the trial. The implications for it are a little bit different. As with every boosted PI trial, we saw no evidence of resistance in any of the patients in that 6 or 7%.
I'm going to go out on a limb and say that that property that you just underlined, no resistance on the boosted PI, is kind of what is preserving the boosted PI as a commonly chosen initial regimen. Maybe not the most commonly, now that we have all these other choices, but that's remarkable, isn't it?
It is remarkable, and it is actually one of the most reassuring things about HIV medicine is the fact that theoretically the boosted PI class of drugs should remain fully active if we never use an unboosted PI first. We should be able to maintain that class. However, I'll push back and say that while I totally agree that you could use that as a rationale to start with that class first, you can also use the same rationale and say you can start second. Because you can use that boosted PI after whatever you did first, and if it doesn't last forever, the boosted PI is sitting there fully potent and ready.
True. So let's see the resistance of the other regimens.
Well, as you can see, it's around 6 to 8% had virologic failure, but only about a third show evidence of resistance. The patterns of resistance are easily summarized on the elbitergovir regimen. In that roughly 2%, they have both integrase and nucleoside resistance. On the efavirenz regimen, they have evidence of non-nuke resistance, but they had fewer rates of nucleoside resistance, a pattern we've seen before as well.
One thing that our participants should know is that with increased use of raltegravir and now elbitergovir cobicistat-based regimens, if the patient has virologic failure, they need to get a special genotype to get the integrase resistance. It is not offered on a standard genotype. I heard there is one commercial platform that now gives you the full 4 drug classes, NRTI, NNRTI, PI, and integrase. But probably at a price premium. So make sure that if you have virologic failure on your integrase-based regimen, that you check for integrase resistance.
I agree. And because as you can see in this particular slide, just because you have virologic failure on an integrase regimen does not mean you will have integrase resistance, and you want to know it because we have drugs in the pipeline.
You got it.
So I totally agree with you, everything you said.
Not surprised you agree with me.
As usual. So then let's compare the use of these drugs. Since all of them seem to do equally well, then how would we pick? So this table is a variation of perhaps the version you've seen, in which I've summarized the adverse events that were reported through week 96. But what I've done is I've put them in order, first of all, of those that happened to at least 10% of patients regardless of their arm, but only those that were 5% or more different between the cobicistat elbitergovir arm and either of the controls, to look at not what was the same, but which ways they differed. There were actually only 2 adverse events that were more frequent on the elbitergovir regimen than either control. Nausea was actually similar to the boosted atazanavir and a little bit more than efavirenz, and headache, which is 2% more than what occurred on boosted atazanavir. You can see in terms of diarrhea, there was actually more on the boosted atazanavir arm. Of course, icterus more on the atazanavir. And then there were 4 toxicities that were more common on the efavirenz arm. Now, this, of course, I think gives a helpful snapshot of which things are the same, which things are different. This is what's different.
Oh.
But what's not clear from a table like this is what gets better. Since if somebody has a toxicity at week 4 and it gets better, at week 96, they're still called a case.
Yeah.
So thankfully, in some recent trials, we've had a chance to look at time-updated adverse events, as you know. So this is time-updated now for the GI toxicities of diarrhea and nausea. As I mentioned, diarrhea was a little bit worse on atazanavir, and indeed, through week 96, there's about 5% more patients who have diarrhea on boosted atazanavir than elvitegravir/Cobi.
Yeah.
This was helpful because, of course, the role of the booster in diarrhea was not clear, and I think here it's clarified.
Yeah, no, and also it may be, remember we used to use PI monotherapy, they also have GI side effects.
Yes.
So even though unboosted atazanavir is a relatively well-tolerated PI, it's probably contributing something to this GI profile.
It certainly could be. So I think this clarifies that there may be an advantage to one booster over another. That 5% difference is exactly what we saw in the cobicistat versus ritonavir trial, in which atazanavir was given in both arms. There was 5% more diarrhea on atazanavir or ritonavir than atazanavir/Cobi. So I think some of this, actually, I would surmise, might be the Cobi versus ritonavir effect.
We'll see.
So in terms of nausea, however, while there is a little bit more initially on the Stribal regimen and on the ritonavir atazanavir, over time it actually equals out. So after a month, all the arms have about 3 to 4% through 2 years.
Yeah, and reassuringly, nausea as a cause of treatment discontinuation was extremely infrequent, maybe a couple of cases, if I remember correctly.
I think that's right. I think we have that table coming up. So most of this is, I agree, grade 1 in transit, which is helpful to support our patients. If you have something at week 1, stay with it. By week 2 to 4, it might go away. The same is also seen for the CNS toxicities, but again, what was seen is a difference over time. Even though things improve, they don't necessarily converge to the same number. I've looked at abnormal dreams and dizziness, and you can see over time there was more abnormal dreaming reported on this double-blind trial of efavirenz versus the alternative, and a little bit more dizziness even through week 96 versus the comparator arms.
Can you comment on something?
Sure.
And I want to hear how you,
Yeah.
a brilliant clinical trialist,
Yes.
explains this.
Yes.
Ready?
Go ahead.
Why is the rate of CNS abnormalities, especially abnormal dreams, different in the 2 different studies for the elvitegravir/cobicistat strategy?
I think this is actually one of my favorite teaching slides because in the world of teaching clinical trials, this is a great example.
I couldn't agree more.
Yeah.
Explain it.
So first, let's take a look at the numbers. Just because the legend's not clear, 8% of patients on the elvitegravir in the ATRIPLA study complained of abnormal dreams at week 96. In the atazanavir trial, only 1% did. So how could the same drug have an 8% and a 1%? And I think the reason's obvious. In the consent form for the ATRIPLA study, you read you are on a pill that might cause you to have abnormal dreaming.
50% chance.
Exactly. And in the atazanavir, it mentions nothing about abnormal dreaming because we didn't think atazanavir did it, nor did we think elvitegravir/Cobi would do it.
So the nocebo effect.
The nocebo effect, I think this is the power of suggestion. I think we've learned that if you tell people you might have an abnormal dream, 8% believe you.
Yeah.
But we do see that even with the nocebo effect, another 5 to 6% will, on efavirenz, have that side effect. So it also confirms that efavirenz has a real effect that isn't simply just suggestion or bias, but it is persistent and different in a double-blind trial. So I think this is some of the clearest data we have that whatever happens on efavirenz doesn't always go away, though it sometimes does not always normalize.
Do you think if efavirenz were up for FDA review today with the other alternatives that we have, that the CNS side effects would get more scrutiny, or you think that it would just be, most of it goes away after a week?
Well, so I think most of it does go away after a week, but it doesn't normalize and doesn't necessarily go away. I think that efavirenz would likely get approval. It's certainly a great drug and has its place. We've all used it for years and thousands of patients have been successfully treated with it. But I have a feeling we might feel differently about it as our gold standard if it were showing up now in the sequence of things, because it does have a couple of toxicity issues that remain clear in study after study lately. Another piece of the puzzle that was reassuring here is the comparison of bone mineral density, which we know can be a concern for some tenofovir regimens. Here, what we can see is that there's more bone mineral density decline on the boosted atazanavir than on the elvitegravir arms. Now, that difference is around 1%, and it's certainly in the spine on the right, you can see that there's even a trend improving on the elvitegravir, whereas it's stable or perhaps slightly declining on the atazanavir. So this was a reassuring piece of the puzzle for, again, how we move towards safer regimens. Again, acknowledging that we're not sure how much to worry about this.
Yeah, it does seem that almost universally, once antivirals are started, there's a decline in bone density. And maybe the best explanation I've heard, although it's not proven yet, is that some of this is a phenomenon of immune reconstitution.
Yep.
That the consequences of improving your immune system, CD4 increases, et cetera,
Yep.
is a slight imbalance between bone resorption and bone formation, and that might be the case.
I think there's at least 2 or 3 issues. One is certainly a drug effect. I
Yep.
think there's clearly a drug
Oh,
effect.
yeah.
We've seen it in suppressed patients, so we can see some improvements
Yes.
or declines. I think the other is that HIV itself, of course, causes bone mineral density decline. And so if you imagine what that curve looked like before the person started, if they are on the decline because of untreated HIV, it may take a while to slow down the decline caused by HIV.
Yeah, I as much as I hate to disagree with you, I don't think that's it totally.
Okay.
Because remember, the only benefit of intermittent therapy in the START study, SMART study,
Yep.
was bone density.
That's right.
So,
Yep. Again, another controversial area in our field.
okay.
So let's take a look, of course, at the lipid fractions, and you can see here all 3 of the groups are summarized, and while there are some significant p-values, clinically these differences are pretty small. So the LDL difference, again, while there's a p-value nearing significance, similar for the HDL and total cholesterol, I think we would say clinically these are, on average, more similar than different, certainly for all the important lipid fractions, and to the extent, again, that the ratio tells us something, they were similar in all 3 arms of this trial. Again, giving us a profile that this is now another, in our case, 3rd single tablet regimen we have available for whom the right patient with a GFR greater than 70 at the beginning could consider this. So a little bit more about that GFR issue. One thing about some of our antivirals is that they cause a change in the measurement of serum creatinine. You can see right here that in the first weeks of the trial, patients who got the cobicistat or the ritonavir-based regimen have a small but clear increase in serum creatinine. And you can see that does not occur on the atripla or the efavirenz arm. And you can see on the right that all of it happens by week 4, because if you plot what happens from week 4 on and use week 4 as the new baseline, you can see almost no change for 2 years. So what is this? We've had some work done on this, and what we know is that this is a change in how creatinine leaves through the tubule. We know that in part because by using a drug called iohexol or a substance called iohexol, we can see that glomerular filtration is not changed in the presence of cobicistat, not changed with ritonavir. But what happens is that we block the pathway that creatinine leaves through the tubule, so it builds up a little bit, and that backup is what's shown in these data slides.
Any consequences to this tubular inhibition of secretion of creatinine?
So we've asked our nephrologists exactly that, since after all, if it's blocking creatinine through a tubule, what else goes through that pathway, and is something endogenous going to happen to us? So fortunately, we've had a couple of decades of drugs like trimethoprim, like cimetidine, that block this same pathway, and our nephrologists tell us that they are not aware of any renal toxicity associated with drugs that block this pathway. So based on history, we have nothing to know that we should worry about. Though our eyes are open.
Yeah, I mean, however, we have to remember these are tenofovir-based regimens.
Exactly.
So how can the clinician
Put this
tell
together.
This benign increase
Absolutely.
from something that's happening secondary to tenofovir?
Exactly the key issue, because ultimately this doesn't exempt you from tenofovir toxicity, and the only question is, how do I handle both? Well, the first is right here on this slide. This change happens in the first 2 weeks. So what I think is pretty clear, and the FDA guidance is very clear, is a patient who starts on this, have the GFR done, have the serum creatinine done at baseline, do it again at week 2 to 4.
Which we would do anyway.
Hopefully.
I mean, it's just good
Hopefully.
practice
Absolutely.
to have a baseline creatinine.
Absolutely, makes perfect sense. And then get another one at week 2 to 4. If there's a delta, if there's a change between baseline and week 2 to 4 in that patient, that's the Kobe effect. Whatever happens from that point afterwards is something else. It could be tenofovir, it could be something else, nonsteroidals, other drugs, but it's unlikely to be the Kobe effect.
And some of the signals that it's something else, just so that they're aware, it would be an increase of greater than...
Well, let's take a look at this.
Yeah.
Let's take a look at this slide, because what we see in terms of the something else. So if we see the initial change due to the cobicistat, then what happens in terms of toxicity? Toxicity isn't a change in serum creatinine measured in this pathway, because this pathway we think of as benign. So what is a renal event? So in this study, a renal event is defined as we have for decades. When we look at tenofovir-associated renal events, we're talking about tubulopathy. We're talking about progressive changes either in increases in serum creatinine that are progressive over time, or changes in tubular function, proteinuria, glucoseuria in a non-diabetic, phosphaturia, hypophosphatemia. We see changes that are associated with changes in renal function that are beyond simply a small isolated change that's stable in serum creatinine. So I think it's pretty easy to tell the difference because one is benign and quick and stable, the other is progressive and getting worse over time.
And numerically, it appeared, at least in these studies, that none of the cases of tubulopathy had an increase of less than 0.4 milligrams per deciliter. So 0.3 and below, it was benign. 0.4 and above, you have to look.
Exactly.
So it doesn't mean it is tubulopathy, but it could be.
Exactly. And so that's what's summarized here is that those patients who had so-called renal events, renal toxicity, were all in the bucket of patients who had the greatest increase when they started on cobicistat, of the greatest increase. How those two are connected isn't clear, but I agree it's an easy signal for us to use in the first 2 to 4 weeks to say this is the patient that I want to monitor closely, and these are the patients in whom I would worry as much as I worry about any patient on a tenofovir-containing regimen.
So what happened to inulin?
What happened to inulin? Well, it's another measure of way to measure clearance.
I guess iohexol is preferred these days.
Well, certainly it was in these studies.
Okay.
So, and you can see, I think we mentioned this earlier, this was the only toxicity that led to discontinuation in cobicistat of a greater than 0.5%. You can see the other reasons listed there, and there was one patient with fatigue, one with nausea. After 2 years, you can see the very low rates of toxicity leading to discontinuation. So other than renal monitoring, subjectively, this drug was very well tolerated by patients.
Great.
Yeah. So that's that story. So how do we do even better?
Well, yeah, I mean, what's in the pipeline?
Exactly.
Because, you know, once you get to be so successfully treated and you have so many good options, how can you improve on these?
Well, we've just talked about one, which is how do we do even better with less renal toxicity? And so since tenofovir is associated with all of these regimens, and there is this potential for renal toxicity, is there a way to modify tenofovir to have even less renal toxicity? So that's the point of tenofovir alafenamide, also known as TAF. TAF, which is of course the abbreviation for a different salt of tenofovir. Instead of the disoproxyl fumarate that we've been using for over a decade, there's another salt of tenofovir alafenamide.
Can you draw the chemical structure for me, please?
I can. I'll do that for you later. It's a fascinating one. But what I can say about it is because of its chemical structure and because of how it gets activated in some of our cells, we can use it at a much lower number of milligrams to achieve the antiviral properties that we do with 300 milligrams of tenofovir disoproxyl fumarate. How do we know this? There was a 10-day monotherapy trial that compared 3 low doses of TAF versus the standard dose of TDF.
Yeah. Much lower. I mean,
much lower, like by 90% lower. And you can see on this curve, although these curves are a little bit complicated, but nevertheless, the top is the placebo group with no virologic change. And for 10 days, you can see that TAF has a either similar or even greater drop in viral load compared to tenofovir disoproxyl for 10 days.
So really no concern about antiviral potency.
So at doses of even 10 milligrams or higher, we have the same potency that we have for TDF. And because this drug actually gets boosted by cobicistat, we can actually use 10 milligrams of TAF to give you the 25 milligram line that's shown here, which is actually somewhat more potent than what we see with just tenofovir. So then if we take a lower milligram exposure in the body, in most cells, you're going to see lower exposures, but in lymphocytes, this drug is activated.
Any other benefits to having a low dose besides?
Well, other than a smaller tablet, of course. So the other advantage is that the low dose allows lower exposure in cells that don't activate this drug. And so hopefully we'll see less renal toxicity, less bone toxicity in cells that are seeing much lower milligrams, to the extent that this is a dose-related phenomenon.
I've also heard that a lower milligram amount leads to a much lower cost of production.
Interesting.
And, you know, which is one of the reasons, sadly, that there's still so much stavudine being used in the world, because it's so incredibly cheap and the doses are so small.
That'd be great. So that'll be a great outcome if that's the case. So efficacy-wise, is not surprising. We saw the exact same efficacy on the TAF arm as we saw with the TDF arm. This is now with a regimen of FTC and then boosted elvitegravir. You can see with 90% success at week 24, regardless of the arm, similar increases in CD4, similar increases in adverse event profile, very small differences of all the adverse events. But what we did see is perhaps some evidence of the benefit we were looking and hoping for, which is that on TAF you can see that there is less decline in spine bone mineral density, much less decline in hip bone mineral density. Indeed, the bottom line there, the percent with no change in bone mineral density is almost 2 to 3 times higher on TAF than there is with TDF.
Yeah, these are, aside from, I believe, one relatively small study of lopinavir, ritonavir plus raltegravir.
Sure.
These are the best data on bone density changes we've seen in any HIV clinical trial.
I agree. No, I think this is great data, and one of the reasons why the field is excited to see this drug being developed in phase 3.
I was actually surprised.
Yeah.
So it was this good.
Yeah.
So.
Well, and we also have the renal finding, which again has been an ongoing discussion as to how do we do even better than the small differences attributed to tenofovir. Here you can see that cobicistat effect, but for reasons that aren't entirely clear, there's also less of an impact on the TAF arm than the TDF arm that shows up early on, and then it's persistent for week 24. Again, it's a small difference. Clinically, it's not clear how much this matters, but nevertheless a favorable one favoring TAF over TDF. Okay. So we've got that in the pipeline, and phase 3 is moving along quite nicely. We also have the lipid differences, which paradoxically favor TDF. TDF has always had this interesting lipid lowering property. Here, when we give now less to TDF, we're giving it as TAF, we see less lipid lowering properties. So we can see that here. Again, not that anybody's necessarily using tenofovir for lipid lowering properties, but you see the curve with more of an increase on TAF, just as you'd expect given what tenofovir can do. So, TAF is in our pipeline, and so is a new integrase inhibitor called dolutegravir. I've summarized here 2 phase 3 trials of dolutegravir, the SPRING trial and SINGLE. These are double-blind trials. The SPRING study was dolutegravir with 2 nucleosides versus raltegravir and 2 nucleosides. The clinician had choice between Truvada or Epsicom, TDF, FTC, abacavir 3TC. And I've summarized all the different ways you can summarize antiviral efficacy below 100,000 and above, less than 350, greater than 350, and you can see overall the message is pretty clear. Dolutegravir does at least as well as raltegravir at every single one of these analyses, and maybe a hint of some better outcomes in some of the subsets like high viral load. In the SINGLE trial, this was dolutegravir or abacavir 3TC specifically versus tenofovir FTC efavirenz.
Separate tablets.
Separate tablets. In this, there was no single tablet of dolutegravir yet studied, though one is anticipated. That was not done in this particular trial. And in this particular study, once again, you can see the differences favoring dolutegravir. So although we can summarize that the difference is all due to adverse event differences. Antiviral efficacy is the same. It's just better tolerated.
I mean, this is an interesting study, the second one in particular, for a number of reasons. First is that it compared 3 completely different drugs.
Right.
We haven't seen that in quite some time.
That's right.
Second is that it was sort of historic that there is now something that beat efavirenz-based regimen, because we haven't seen that before either. Right. So, yes, the reasons were not virologic. Right. They were adverse events, but that gets back to what you were saying before about efavirenz and adverse events.
Exactly.
So, I thought that study is particularly important. The first one versus raltegravir has been published. The second one is sort of floating around, and we hope it'll be published soon.
I'm sure it would. So, and in terms of the the differences between in the SINGLE trial, I agree that dolutegravir versus efavirenz in this particular, while the nucleosides are different, that raised one of the concerns: would there be a difference in antiviral efficacy because abacavir 3TC has the question mark above 100,000? Certainly, you can't see that problem here. You don't see the abacavir 3TC underperforming versus tenofovir FTC. So that problem may go away. That may be because dolutegravir is so prompt at establishing virologic control that we don't have the problem. You get to less than 50 soon enough to not worry about it.
And it's worth also emphasizing that that 100,000 threshold was seen only when it was paired with efavirenz or with atazanavir ritonavir. It was not seen in the study where lopinavir ritonavir was used as the third drug.
Sure. So there is that one as well. So this kind of summarizes a lot of data, and ultimately what we can see is that dolutegravir is at least as potent as any of the preferred regimens that it's been compared to so far. In terms of tolerability, it certainly continues to do very well. This is the comparison with raltegravir, considered one of our best tolerated drugs of all. And as you can see here, the rates of adverse events were low, low in both arms certainly, though not zero. There are some patients who do have some toxicity. So I think it's just important to remind ourselves that while the rates are low, they are not zero, and we can see toxicities in patients taking a dolutegravir-containing regimen. You can see, for example, there were some serious adverse events, and 3 of which were considered potentially drug-related, including 1 case of hepatitis. Of course, there were some on the raltegravir arm that we don't think of as raltegravir-based adverse events like convulsions. Nevertheless, it's just an open mind to realize that rare toxicities can still happen to our patients.
Now it says hypersensitivity in the dolutegravir arm, and of course in some of the patients in this study also received abacavir. I assume they were all HLA-B5701 negative?
Absolutely.
Yes, okay.
Nevertheless, sometimes a clinician can say, I think I'm seeing it anyway, although as we understand it, that's extremely unlikely to be the abacavir.
Okay, good.
And you could also see the few patients who had adverse events leading to withdrawal, but again, some of which were not even drug-related, again, like the development of acute hep C, as I mentioned earlier. So, in terms of the single trial, which was, again, the comparison to efavirenz, this is where we see the biggest difference favoring dolutegravir. Again, this is blinded, so you can see that the patients will have some toxicities that are perhaps more due to the efavirenz nocebo effect happening to those on dolutegravir. But interesting enough, in this trial, for whatever reason, there were more cases of insomnia on dolutegravir than efavirenz. Probably just a fluke of just random chance, as opposed to some signal, since it didn't show up in the other study of dolutegravir. You can also see small numbers of patients with LFT increases. Overall, the drug looks quite safe, certainly with rare toxicities, if any. And so the only difference that really showed up here is that there were more toxicities leading to discontinuation on efavirenz than dolutegravir, just like we talked about earlier for the STAR trial, less than 100,000, just like with raltegravir in the 5-year comparison at START-Merck. Efavirenz has a liability. And as we've talked about earlier, there are changes to serum creatinine that we consider benign. Here it is one more time now due to dolutegravir. There's this increase in serum creatinine, and it changes the estimated GFR, but does not change the actual GFR. And that you can see here is prompt. It happens at week 2, and then it's persistent for the 48 weeks that's summarized on this slide.
About the same magnitude as cobicistat.
Looks that about, just about the same thing. So we are seeing, again, something that clinicians are going to have to perhaps at least be familiar with. They can't dismiss it. And again, it's not complicated. Just measure at baseline, measure at week 2 to 4. You'll see the difference. If you see a difference, that's the drug effect. Anything from there forward is something else. And so it's really not too complicated to work with and get comfortable with. It's not a complicated thing to measure. So the only other thing that's really outstanding about dolutegravir has been what we see in terms of the lack of resistance showing up early. So you can see there are some cases of virologic failure, viremia despite starting study. And genotypes were done at the time of virologic failure, although importantly, as we understand it, they're done on the first specimen associated with failure, which means that there's less time failing, if you will. Nevertheless, what we see so far is a lack of resistance, 0 patients with integrase resistance, 0 with nucleoside mutations. The numbers are also very low for raltegravir, with 1 raltegravir mutation and only 4 patients developing nucleoside mutations on raltegravir.
So it could be a combination of both a greater potency / higher barrier to resistance to dolutegravir and about, study methodology.
Exactly.
Could be.
Yeah, it could be. I think what we can say here is that the rate of raltegravir resistance is so low that it's hard to know if dolutegravir is that much better from this single study.
Okay.
On the other hand, we also have the resistance data from the single trial versus efavirenz, and while the methodology has the same issues, there are some failing patients. Once again, no nucleoside resistance, no integrase resistance, and there was a little bit and some on the efavirenz arm, as you can see here with 4 patients who did have resistance. So if there is a difference favoring a drug, dolutegravir seems consistent in the lack of resistance, at least when used as an initial regimen.
Before you go on to the next study, a question from our watchers is just about dolutegravir and cardiovascular safety. Do we have any information on that, or lipids, or?
We have no reason for concern. Certainly the lipids are pretty neutral on this drug, so we have not seen any reasons for concern. As we know, the cardiovascular safety is really divided into two things. One are the things that we can predict for risk factors, like lipid changes, and then there's the bucket of things we don't entirely understand but see in observational trials, like the historic DAD effect for abacavir and perhaps DDI. We don't see any signal here for a lipid problem, and it's too early to know if there's any other concerns based on inflammatory markers. We haven't seen any inflammatory markers that I'm aware of yet for dolutegravir versus our other options. So this is the resistance piece, and the only last piece to get into is that dolutegravir has also been used in patients who are treatment experienced. Those 2 studies were just treatment naive. Here's the treatment experience studies. There are really two categories of treatment experience. I've only included the data here for the treatment experienced patients who are integrase naive. So this is a study design of patients who had been on something else, not yet used an integrase, but virologically failure. Now it's integrase versus integrase plus an optimized background regimen. The optimized background regimen was stratified on whether the darunavir was used or not, as well as the number of fully active drugs. This is the kind of trial that we used to do a lot of because we had a lot of failing patients with viremia and perhaps some loss of drug options, so they needed to resuppress with something. These trials are getting harder and harder to do. Nevertheless, in terms of just a piece of our history and understand how dolutegravir might compare to raltegravir, here are the data. This is week 24, the planned interim analysis. And what we can see is that at least at week 24, there's a little bit of a separation between week 16 and 24. Not clear how to explain that. But nevertheless, if there's a difference, it favored dolutegravir having better suppression than raltegravir. And you can see that showing up here.
Yeah. So, I mean, actually, it's an interim analysis, but importantly, the patients had all been through week 48 when they did this,
That's
correct?
True.
Okay,
that is true.
So
And in fact, as I understand it, just looking ahead at the website, at the IAS meeting, we are soon to see the week 48 full results of this trial.
All right, so we're gonna finish up now, but I have a couple more questions for you. Okay, one is talk about these newer integrase inhibitors and use in treatment-experienced patients. So we've got the co-formulated tenofovir FTC elvitegravir Cobi, and then we have this new one about to be approved, dolutegravir.
Right.
Who can use that if they're treatment experienced?
Well, so there's obviously lots of there's two buckets of treatment experience that would probably make it easier to talk about. There's the virologically suppressed patient who has every drug available to them.
No resistance.
Because they're virologically suppressed.
Yeah.
So that patient has essentially all of these options open, since any of them could be used interchangeably. Obviously, again, the EGFR issue of the elvitegravir Cobi is there, although again, some of that is historic. That was the entry criteria to enter the phase 3 studies. There are studies now going on to look at lower EGFRs, because after all, the change to serum creatinine is not considered a toxicity, so it was really done for study simplicity. We are now doing the studies to look at lower EGFRs at baseline. So with that exception, if a patient is virologically suppressed, they can use any of these in a new regimen. And there are switch studies of going from regimen X to the single tablet Stribild, for example. So those kinds of things make sense. No doubt there'll be some for dolutegravir. There's also the treatment experienced patient. Here, it's a little bit more complicated.
Let me give you a typical one.
Exactly.
Darunavir, ritonavir twice daily, etravirine twice daily, raltegravir twice daily.
Right.
Can they switch over to the Stribild to simplify their regimen?
So let's get into that. So there's the patient with historic resistance in which there's a lot more at stake. So first rule is that dolutegravir can certainly be used instead of raltegravir, since at least metabolically the pathways for metabolism are very similar, so they can be used interchangeably. As far as we know, there's really not a reason to use one versus the other than raltegravir as twice daily, dolutegravir being once daily, and certainly looking at least as good in terms of the virologic data I've shown you. Dolutegravir has an important property in which it seems to be active against some resistant variants, resistance to raltegravir or elvitegravir. Dolutegravir might overcome and be potent against some of those resistance. So dolutegravir will have that extra niche in a patient who's failing raltegravir, like we talked about earlier, to find out the mutations and see could I use dolutegravir in a new regimen, although it'd be hard to construct what that new regimen is. However, we also want to get into the PK. I know you want to get there, so let's
do it. I really do.
So let's
it's important that people understand.
I totally agree with you. So it turns out that, as we talked about, elvitegravir requires a booster cobicistat. Elvitegravir and cobicistat are substrates of the cytochrome 3A4 system. So anything that induces or revs up that enzyme system will lower the exposure to both of those drugs. And unfortunately, darunavir is such an inducer. So darunavir, when co-administered, will lower the exposure of cobicistat, lower the exposure of elvitegravir. So as a result, we cannot successfully put those three drugs together because at the current time, we'll just get underexposure of all three.
And there's also this P-glycoprotein effect of these drugs. So it's very complicated.
It is.
And just, you know, nice the way you divided it between the stably suppressed patient, who has many, many options versus those who are on the complicated salvage regimens that we created in the late 2000s for patients with a lot of drug resistance.
Exactly. Okay. But there is interest in clinicians of using Strival because of the simplicity. It's got that cobicistat. If it can't successfully boost darunavir, at least for the reasons we talked about, could it boost another PI? Yeah. So there is some discussion of could it boost atazanavir, for example, since atazanavir isn't as much of an inducer of the 3A4. So there is some room for future trials to understand, could I use, for example, the Strival plus atazanavir and, quote, get away with it. Good. So some work yet to be done.
Cal, I want to thank you very much, and I want to wrap up now. And I would like to thank Gilead Sciences, Boehringer Ingelheim Pharmaceuticals, and Vertex Pharmaceuticals for their support of this important educational series, in addition to educational support provided by the Centers for Disease Control and Prevention. And please remember to complete the quiz at the end of the session to secure your CME credit. And stay tuned for the next session, New HIV Screening Recommendations for Primary Care Providers, with Dr. Jeffrey Kirschner and Dr. Amir Kasim. My name is Dr. Paul Sachs, and thank you very much for joining us.